Hello, welcome to this, the final module of the Ultrasound Plus course. And it is a hugely abbreviated introduction to the world of echocardiography. So with this short lecture, I hope to pique your interest further into this challenging and really fascinating employment of ultrasound. Cardiac patients can present in a number of ways, with or without a heart murmur or arrhythmia. Vague clinical signs such as a cough or exercise intolerance may be present, or more severe signs such as syncope, dyspnea or collapse might have brought them into the clinic today. A comprehensive cardiac assessment requires the employment of ultrasound, absolutely. Additionally, radiographs can deliver important information on the thoracic cavity, pulmonary parenchyma and vasculature, which may all have changes secondary to cardiac disease. Assessment of the heart itself with radiographs is limited, of course, to assessment of the size of the cardiac silhouette and, of course, portions of it. A resting ECG is a very helpful tool for assessing numerous cardiac conditions, whether an arrhythmia has been auscultated or not. Cardiac blood panels, so NT-proBNP and cardiac troponin I, can be a helpful adjunctive tool, particularly in certain cases. So when might you decide to perform an echocardiographic examination? You might decide to perform an echo in patients that present to your clinic with a heart murmur. It's currently actually recommended that older patients with a heart murmur of grade 2 or above should be offered an echocardiographic examination. I think you probably know that approximately 50% of puppies will have a benign flow heart murmur, and these are usually of a low grade, perhaps a grade 1 or 2 out of 6. If the heart murmur is louder than this in a young puppy, then an echo is absolutely recommended as soon as possible. But for those puppies with lower grade heart murmurs, once they persist past 4 months of age, an echo can be recommended. Remember, disorders like subaortic stenosis develop with the heart and the patient, with a peak pressure gradient associated with stenosis only being recorded at 18 months of age and not sooner, actually. An arrhythmia should always be assessed. A resting ECG is the first port of call, of course, then a Holter if necessary, but an echocardiographic examination should ideally be performed to assess for structural abnormalities inciting the detecting arrhythmia. When it comes to cats, they are, of course, more challenging. So in summary, not all cats with a heart murmur have cardiac disease. Not all cats with cardiac disease have a heart murmur. And in cats that have a heart murmur, 18 to 62% have hypertrophic cardiomyopathy, hugely variable. Auscultation of a heart murmur in a cat does not always indicate disease. Regarding patient preparation, I always recommend placing an intravenous catheter in the left cephalic vein rather than the right, if possible. The patient will be recumbent for the majority of the time on their right-hand side, and the assistant will need to pull the dependent right limb forward to help to open up the axillary region as such, improving the acoustic window. And if the catheter is in the right leg, it can quite easily become dislodged, and that's the last thing we need in a potentially critical patient, right? Regarding sedation, it isn't always necessary, absolutely isn't, but it can be very helpful. I usually recommend that cats have gabapentin the night before and morning of. Dogs, they can have trazodone or gabapentin or both the night before and morning of. Very often I give butorphanol once the patient is in the clinic, typically 0.3 mg per kg IV or IM. And very often, if it's really necessary, I will happily administer alfaxolone. In cats, IM, and in dogs, IV, often diluted. We obviously don't want to use drugs that may significantly alter hemodynamic conditions for the echocardiographic study, but these drugs are typically absolutely fine to use. Regarding the clip margins, ideally clip the hair in an approximate triangular shape as demonstrated here in the axillary region of the patient both sides. In emergency situations, just parting the fair and spring surgical spirit allows an acoustic window for imminent diagnostics guiding urgent stabilisation. Utilising an echo table, such as the spotty one here, will make everything much easier. The heart will lie nicely against the chest wall and will be visible in the cardiac notch between the dependent lung lobes. Performing an echo in standing is actually really challenging, as lung tissue will just get in the way, particularly for anything around the heart base and above. The scan will be performed in both the right and left lateral recumbency, always, but this lecture is going to focus briefly on the standard views obtained in right lateral recumbency. For cardiac scanning, it's recommended to utilise a cardiac, sectoral or phased array probe, all names for the same thing. The footprint of this probe is nice and small and should easily fit in the intercostal spaces. Helpfully, this transducer confers an increased temporal resolution. So temporal resolution represents the ability of an ultrasound system to distinguish between rapidly moving structures from one frame to the next, such as the movement of the heart in the cardiac cycle. Microconvex probes typically do not have high enough frame rate, and thus the image may blur a little bit. The phased array probe, like many other transducers, is very often a multi-frequency probe. However, the range of frequencies attainable is much smaller than the microconvex probe. Therefore, it can often be necessary to have a probe suitable for cats, middle-sized dogs, and a third for giant breeds. That's life goals right there. Most clinics do generally only have one. It's typically the size for sort of medium-sized dogs. Ensure the correct patient probe setting has been selected on the machine. Large dog heart or cat cardiac, for example. A vast quantity of the information necessary for a cardiac diagnosis, in many instances, is going to be obtained from the right parasternal 4-chamber view. This is the home view, as such, and it's the view the echocardiographic examination always begins with. This is obtained when the patient is lying in right lateral recumbency. Palpate where the apical beat is strongest and place the probe here. The probe should be perpendicular to the patient, with the notch of the probe directed towards the sonographer. Now, in most instances, to obtain standard views, which can then be easily correlated to images in textbooks, the image will need to be reversed on the screen. There will be a reverse button somewhere on your machine. It may be found on the screen of the machine as a left-right switch tab that you can click on. According to convention, the apex of the heart in the right parasternal long-axis views should be on the left of the screen and the atria on the right of the screen. It's very useful to follow this standard image orientation, as understanding the cardiac anatomy can be incredibly challenging initially. In these images here, the image on the left has been obtained following my initial setup, and then by clicking the reverse button, I obtain an image with the apex on the left of the screen and the atria on the right, which is standard echocardiographic positioning. So what are we actually going to try and image when we scan? We want to image the left ventricle and the left atrium, the interventricular septum. We're going to image the right ventricle and right atrium to a degree, the mitral valves for sure, and the tricuspid valves to a degree, the aorta, pulmonary artery, and pericardium. Almost all cardiac texts abbreviate the anatomy, and I've put the abbreviations here, and this will take some getting used to. As I said, today we're going to focus on the left side of the heart. So this is the right parasternal 4-chamber view. You're going to hear me saying this a lot. The right parasternal 4-chamber view of the heart of a dog. It's obtained on the right side of the patient, the dependent side. It's adjacent to the sternum and demonstrates 4 chambers. So the right parasternal 4-chamber view, or the home view as it's colloquially known. And this image depicts the left ventricle, the left atrium, the interventricular septum, and the left ventricular posterior wall. And you can see we can really barely see the right ventricle and right atrium in this view. There are both objective and subjective ways to assess the heart. In fact, a lot of what's interpreted is so variable, subjective assessments are highly important. There is a very interesting paper that presented 5 cardiologists with 10 cases each, or something like that, and asked for their interpretation and diagnosis. Each specialist was presented with the same feline patient a couple of times within this study, giving the patient a different name, and each cardiologist gave the same patient a different diagnosis each time. So that shows you how subjective the assessment of the heart, particularly with cats and echo, can be, even when using objective measurements, as the heart is a moving organ, always reacting and always responding. So when performing an echocardiographic examination, there must be subjective and objective assessments of the wall thickness, chamber size and chamber shape, the contractility of the heart, the valves, and of course vascular flow and velocities. This lecture will not discuss pressure gradients and flow velocities. There just simply isn't time, but employing colour, pulse wave and continuous wave Doppler allows integral assessment of the flow of blood through the chambers of the heart and beyond. As promised, let's discuss the standard right-sided views. There are 2 long-axis views and 3 short axis views, 5 right-sided views in total. Each view is useful for certain measurements and certain gross assessment. The long axis views are the right parasternal 4-chamber view, the home view, we've mentioned this before, and the right parasternal 5-chamber view. The short axis views are colloquially known as the mushroom view, the fish mouth view, and the Mercedes sign view. One cardiology enthusiast once told me that 80 to 90% of the information needed can be obtained from that right parasternal 4-chamber or home view. How do we obtain these views? Imagine you are sitting facing the ultrasound machine with the patient up on the echo table, lying in right lateral occlumency to your right. Place the probe at the puncta maxima, where the apical beat is strongest, holding the probe perpendicular to the wall of the patient's chest. The transducer notch should point directly towards you or towards the patient's sternum. Then, moving through these standard right-sided views, we follow the basic rule of thumb moving to bum. Thumb to bum. If your thumb is on the notch of the probe, this probe is held steady against the patient and is rotated, initially just 15 degrees or so anti-clockwise towards the patient's bottom, and then completely orientated thumb to bum for the first of the short axis views. Then, to work your way through the short axis views, you're going to hold the probe steady and begin to flatten it on the patient's chest, bringing the cord of the probe towards you. The footprint of the transducer is becoming more and more angled towards the patient's spine. Again, the views we obtain are the right parasternal 4-chamber view. Start to rotate the probe towards the bum, about 15 degrees, to obtain the right parasternal 5-chamber view. And then once our thumb is pointing to bum, we get the mushroom view. We start to flatten the probe, we get the fish mouth view. And then when the probe is very flat against the patient's chest, we have our LAAO view, so left atrial aortic view or Mercedes sign view. Let's look at each of these views in a little more detail. So the right parasternal 4-chamber view is the home view, as I've already mentioned. You want to assess the left ventricle and left atrium here. The left ventricle should be bullet-shaped. The left atrium should be round or slightly square. We can see the mitral valves between the two. We can look at the pericardial sac, see if any fluid's visible. And the right side, well, can we really see it clearly? The right side of the heart should barely be visible. And when it is overly conspicuous, something is wrong. So we kind of say the right ventricle should be about 1/3 to maybe even 1/2 the diameter of the left ventricle. As you can see in the image on the right here, that right side is markedly increased. That's not normal. What information can this home view give us? So, as I've mentioned, a significant percentage of the answer can be gleaned from this view, and it primarily gives us information on the left side of the heart. So the chamber shape and chamber size. Assessing the chamber size, it's really quite subjective, but in cats we can measure the left atrium. We'll talk about that in a minute, and that is an objective measurement. We can look at the contractility subjectively and look at the valve anatomy and valve movement. And of course, we can also assess for pericardial effusion here too. You can appreciate in the image on the left ventricular posterior wall and the interventricular septum are running approximately parallel to one another. This makes that left ventricular lumen in diastole appear bullet-shaped, the tip of the bullet being the cardiac apex. The image on the right now shows a marked rounding of the heart. The left ventricular lumen is definitely more rounded, subjectively speaking, and you can perform measurements assessing the sphericity of the left ventricular lumen, but at a basic level we already can see that it's happening. And you can further appreciate here the bulging of the left atrium past the lumen of the left ventricle distally in your image, likely demonstrating in this patient a dilated left atrium. So this quick, useful measurement you can perform in cats is assessment of the left atrial size in the right parasternal 4-chamber view. You can transect the left atrium or measure, like this, perpendicular to the valves while sort of transecting the left atrium in half. At the end of systole, just before the mitral valves open, the left atrial width should measure less than 16 millimeters, and this is fairly uniform between cats. Moving on to the right parasternal 5-chamber view, we've now rotated our probe ever so slightly, thumb towards bum, and now we can see the left ventricular outflow tract, LVOT, and this is the pathway from the left ventricle into the aorta. And here we can assess the aortic valves and the colour flow. So checking for aortic or subaortic stenosis can be challenging, requiring a good knowledge of what normal looks like and employment, of course, of spectral Doppler techniques, so your pulse wave and continuous wave Doppler, which is outside the remit of this course. But for example, in an older dog with a sudden onset high-grade heart murmur that's very sick, assessment of the aortic and mitral valves in these two images, the right parasternal 4-chamber view and right parasternal 5-chamber view, is a good place to look for the vegetative lesions associated with endocarditis. Now, the first of our short axis views. This is fondly known as the mushroom view and more professionally known as the short axis view at the level of the papillary muscles. So it's a short axis view of the left ventricle, and we can see the right ventricle sort of wrapping around it. It's above the level of the apex of the heart, and within the left ventricle we can see the papillary muscles visible. And it's here that we're going to use M mode. And what is M mode? The mushroom view is perfect for applying this other scan mode, M mode. M mode is motion mode, and it provides a unidimensional view of all structures that reflect ultrasound waves along a given line. Now, when you're using M mode, you're going to have a graph appear across the bottom, a trace appear across the bottom of your screen. Time is on the x-axis, so the trace moves horizontally across your screen as the M mode image is obtained. Obtaining an M mode trace varies between machine, but typically you're just going to click the M button here, and it allows a cursor line to appear. And this cursor line needs to align through the region of interest and can be moved to and fro with the trackball. The M mode trace will appear once the M mode button is typically pressed a second time. It's important to position the cursor so that it transects the left ventricle, as in the second image, the image on the right here. It does take a bit of practice to align the left ventricle appropriately. When M mode is employed, a trace is going to appear below the image of the structure being scanned, like here. And this trace will move across the screen in the direction of the arrows here, as the cardiac cycle infinitely repeats. And this unidimensional trace depicts the movement of the interventricular septum and the left ventricular posterior wall throughout the cardiac cycle. Obtaining an image of the trace by hitting freeze will allow measurements to be obtained. And there are three sections that are measured. We have the interventricular septum, the left ventricular lumen, and the left ventricular posterior wall. These are measured in both diastole and systole. Ideally, an ECG should be utilised to ensure that you are indeed measuring at end diastole, so start of the QRS complex, and end systole, end of the T-wave or peak septal excursion, where the trace is narrowest. The first line of arrows in the image here depicts the measurement of the heart in diastole. So the first pink arrow is going to be the interventricular septum, then we've got the dilated left ventricular lumen, and then you've got the left ventricular posterior wall. The second line of arrows represents the heart in systole. Again, the interventricular septum, the left ventricular internal diameter, or the lumen, and the left ventricular posterior wall. The measurements obtained from M mode trace should be repeated typically 3 times to get an approximate assessment. The obtained measurements will be labelled as such, denoted with a lowercase d for diastole and a lowercase s for systole. So you're going to get 6 measurements in total. The M mode assessment at the mushroom view gives measurements and information on the interventricular septum, left ventricular internal diameter and left ventricular posterior wall in diastole, and then the interventricular septum, left ventricular internal diameter and left ventricular posterior wall in systole. The thickness of the septum and the left ventricular posterior wall can be assessed, and the diameter of the left ventricular lumen in both diastole and systole can be assessed. And from these obtained measurements, the machine can calculate the fractional shortening and the ejection fraction, which are very important indicators of the systolic function or contractility of the heart. So our 2 markers of systolic function, fractional shortening, FS, and ejection fraction, EF. Fractional shortening is the percentage size difference between the left ventricle during systole and diastole. Basically a measurement of how well the left ventricle is contracting, and it should be the fractional shortening between 28 and 45%. The ejection fraction refers to the percentage of blood that is pumped out of the left ventricle with each heartbeat, and it's another measurement of systolic function, and it should be greater than 50%. If you have a very poor fractional shortening, less than 28%, this can indicate decreased systolic function, such as you might see with a very fit patient, or with significant reduction, a patient with dilated cardiomyopathy. And how are these numbers helpful in specific cases? In dogs with mitral valve disease, we very specifically look at the left ventricular internal diameter in diastole. This is an important measurement for staging mitral valve disease. Assessment of the left ventricular internal diameter in diastole is a marker of how spherical the left ventricle has become due to volume overload. For dogs with DCM and cats, but much more rarely, assessing the fractional shortening and ejection fraction allows an objective assessment on the contractility of the heart. So here's an M-mode trace with measurements obtained from a canine patient. Most importantly, we'd like to assess the left ventricular internal diameter in diastole and the markers of systolic function, fractional shortening and ejection fraction. They are most useful in dogs. The machine will be calculating the fractional shortening and ejection fraction from those important six measurements that we're taking. And in cats with hypertrophic cardiomyopathy, for example, we look for the thickness of the interventricular septum and the left ventricular posterior wall in diastole to see if there is an increased thickness, assessing concentric hypertrophy. Moving on to the second short axis view, this is the right parasternal short axis view at the level of the mitral valve leaflets, also called the fish mouth view. It's the valves that open and close that look like the fish's mouth. So this is a short axis view of the heart again. It's now at the level of the mitral valves just below the heart base. So the probe is now starting to be flattened on the chest. Again, with the fish mouth view, M-mode can be utilised. This M-mode cursor is placed through the centre of the left ventricle and measurements can again be made. And this view obtains a measurement of something called the end point to septal separation, EPSS, end point to septal separation. And I know it sounds confusing, but it's basically the distance between the tip of the septal leaflet of the mitral valve and the interventricular septum. If the distance between the highest point of the mitral valve, indicated with the blue arrow, and the interventricular septum, indicated with the pink star, is greater than 7 millimeters, there is concern of widening of the mitral annulus. The end point to septal separation, or EPSS, measured at the white arrow here, is measuring nearly double what it should be at 1.23 centimetres. This indicates marked rounding of the heart, cardiomegaly, and therefore volume overload. I want to ask you to take a second. Which trace do you think is more likely displaying an increased endpoint to septal separation and therefore may indicate a DCM phenotype? Image 1 or image 2? The white arrows indicate the EPSS. The answer is indeed 2. You can see that white arrow is very long compared to the white arrow in image 1. In image 1, you've got a very normal EPSS. You can see the highest point of the mitral valve is close to touching the interventricular septum, definitely less than 7 millimeters. Whereas in the image on the right, image number 2, we can see there's a massive distance between the peak of the tip of the mitral valve and the interventricular septum, suggesting rounding of the heart. The final short axis view to obtain is the LAAO view, or the short axis view at the level of the heart base. And it's from this view that we can get a normalised measurement of the left atrium by comparing it to the width of the aorta. This image should ideally be obtained with the aortic valve, so that's why it's called the Mercedes sign, the aortic valves in view. So with short axis view, the heart, level of the heart base, try to get your left auricular appendage in view, and it's actually quite a challenging view to get, and you're going to be able to measure the left atrium compared to the aorta and get a ratio. Let's go through some anatomy, some basic anatomy visible in the short axis view at the level of the heart base, so the Mercedes sign view or the LAAO view. In the centre of the image, with correct orientation, you get your aorta with the Mercedes sign, that's the valves. To the left, you're going to have your left atrium. And hopefully you're going to be able to see the left auricular appendage too. On dorsally, you're going to have so proximally on your image, you're going to have your right atrium, right ventricle, and your pulmonary artery curving round the aorta. And I want to point out the pulmonary vein here. So very often we see the pulmonary vein coming into the left atrium at this level. And if you include the pulmonary vein in your LAAO measurement, you're going to get an increased measurement, okay? So try to see where the pulmonary vein is coming in and try to anticipate where the wall of the left atrium would actually be, as indicated by the pink dots in this image. The leading edge to leading edge method is employed here. This means that the measurement of the aorta starts at the outer wall of the right side of the aorta to the inner wall on the opposite side, and the left atrial measurement includes the wall of the aorta, taking off from where the last measurement stopped and goes to the inner wall of the left atrium. The ideal ratio between the left atrium and the aorta should be less than 1.6. That is to say, the left atrium should be less than 1.6 times the width of the aorta. Now, these aren't great images by any stretch of the imagination, but you can see the image on the left has an LAAO of 1.51, which looks subjectively too about right. The second image has an LAAO of 3.21, and just by subjective assessment, you can say that the left atrium in the second image is markedly enlarged. In this view, it's also important to look for blood clots or hyperechoic swelling sediment that is floating around in the left atrium or left auricle. This hyperechoic sediment is called SEC, segmented echo contrast, or more colloquially known as smoke. Okay, a couple of quick questions at this point. True or false? Firstly, some people are born with an echo gift. True or false? Nope, plenty of hard work the first few times you do it. The images aren't going to be great, but they will improve with practice. Number 2, it would be ideal to clip the patient's hair to obtain a good image quality. Absolutely true. As ultrasound waves are oscillatory, they require a medium to travel through. Absolutely, so spray with surgical spirit if you would like to, and definitely utilise ultrasound gel. Sedation of patients is a necessity for echocardiographic studies. True or false? Absolutely false. Sometimes we do need certain sedative agents. Be choosy. 5th, the phased array probe is most specifically used for cardiac studies. Yep, called the phased array cardiac or sectoral probe. Much of the initial subjective information is gleaned from the right parasternal 4-chamber view. True or false? Very much true. It's best to place an intravenous catheter in the right cephalic vein. True or false? I personally prefer it in the left. Movement of the patient may interfere with image quality and image acquisition. Absolutely true. The order in which we move the probe to scan is bum to thumb. No, it's thumb to bum. And M mode is a unidimensional image obtained in real time. Absolutely. Well done. So we're going to move on to a very brief overview of common acquired cardiac pathologies. The phenotypic appearance of cardiac remodeling secondary to disease comes down to whether there is a pressure overload of the heart or a volume overload of the heart. All the common pathologies will cause either of these two hemodynamic changes. Being able to observe a volume overload phenotype or a pressure overload picture will help to reduce the list of differential diagnoses. So in this lecture, we're going to focus very briefly on mitral valve disease, dilated cardiomyopathy, and hypertrophic cardiomyopathy. So no better place to start than degenerative mitral valve disease, or myxomatous mitral valve disease, or just mitral valve disease. You'll see all sorts of abbreviations. So mitral valve disease makes up about 60% of all cardiac cases, and it's a degenerative valve disease usually associated with increasing age. The mean onset of age is about 9.5 years. However, some breeds have a younger median age of onset. One large study of King Charles Cavalier Spaniels by Dark in 1987 demonstrated that heart murmurs were present in about 50% of individuals by 4 years of age and 100% by the age of 10. And other studies have demonstrated 90% by the age of 10. Of course, as with most heart disease, males are predisposed. About 30% also have tricuspid degenerative valvular lesions, and about 30% will develop significant mitral regurgitation and subsequent congestive heart failure. So hallmark features with echocardiography, we're going to be seeing changes in the mitral valve. They're going to become thickened, sometimes tethered, and they might flail back into the left atrium. You're going to often have a mitral regurgitation, which can be seen with colour Doppler, which is typically eccentric, shooting out towards the distal wall, the posterior wall of the left atrium. You're going to often end up with an enlarged left atrium and rounding of the left ventricle once volume overload becomes prevalent. Of course, those are just some of the features of mitral valve disease, but the primary purpose of echocardiography subsequent to our clinical suspicion in patients with mitral valve disease is to stage the cardiac disease and implement an appropriate treatment plan. A comprehensive visualization of the heart should, of course, always include a right lateral and DV radiograph too, and the right lateral radiograph is used to perform the vertebral heart score or the vertebral left atrial score. So how do we stage this cardiac disease? This is the standard staging: A, B1, B2, C and D. So A is your at-risk patient, so your breeds such as King Charles Cavalier or Whippets. B1 is there is a heart murmur but no signs of cardiac remodelling as identified with echo. B2, you've got your heart murmur, okay, but you also have signs of cardiac remodelling. You now have a dilated left atrium and a dilated left ventricle. Stage C is there's present or previous congestive heart failure present. And D is there's refractory congestive heart failure. Refractory CHF is congestive heart failure that's not responding to therapy anymore. On the conversation of mitral valve disease, we must talk about the EPIC study. So EPIC stands for Evaluating Pimabendin in Cardiomegaly, and this paper by Bosworth et al. In 2016 was a large randomized multinational study designed to investigate the effect of pimabendin on the progression of mitral valve disease in small breed dogs. The question was, does pimabendin delay the onset of congestive heart failure? And the study identified that small breed dogs with stage 2 mitral valve disease had an average of 15 months delay to the onset of congestive heart failure if pimabendin was commenced in stage B2 rather than waiting to start pimabendin at the onset of congestive heart failure. To stage the patient as B2, 4 criteria, according to EPIC, should ideally be met. So the EPIC study suggests that the 4 criteria that need to be met are a heart murmur greater than grade 3 or above, a vertebral heart score greater than 10.5 or breed equivalent, a left atrial aortic ratio greater than 1.6, and a left ventricular internal diameter normalized to body weight greater than or equal to 1.7. And if the patient fits these 4 criteria, start pimabendin. This patient is stage B2, they should start pimabendin. The treatment for mitral valve disease is typically commenced at stage B2. So no treatment is required at stage A or B1. Perhaps between B1 and B2, a low sodium diet can be introduced or omega-3 supplementation. B2 is where we've proven cardiomegaly. We've got those 4 signs, we've proven them, and it's recommended to prescribe pimabendin. Stage C, fairly self-explanatory. We now likely have furosemide, maybe an ACE inhibitor ongoing, maybe spironolactone. Refractory CHF or stage D means that the patient is on greater than 8 mg per kg per day furosemide, PIMO, ACE inhibitor, maybe spironolactone. And typically the furosemide is not working at keeping pulmonary edema at bay, and changes towards furosemide may or may not have been trialled. And stage D is obviously not a good place to be. I think D stands for, well, poor dogs, stage D. Moving on to dilated cardiomyopathy. This is a DCM phenotype. So dilated cardiomyopathy, we will discuss this in relation to dogs only, briefly. Usually there is often a low-grade heart murmur at the left apex, which may also be heard on the right side too. Typically it's less than a grade 3 heart murmur. Dobermans should, as we know, be screened for DCM as they have a 60% chance of developing this disorder. And boxers, of course, can be screened too. Predisposed dogs should be screened yearly from 3 years of age with both echo and Holter monitoring. Dobermans, for example, with more than 50 VPCs, ventricular premature complexes, over a 24-hour period, or that have couplets or triplets of VPCs, are at an increased risk of developing DCM. So Holter studies are very useful in breeds predisposed to uncontrolled tachycardia-mediated cardiomyopathy such as boxers, but also your Dobermans with familial DCM. So we know that there is, of course, this familial DCM in certain breeds, but there are other causes of a DCM phenotype too. Diet can cause a DCM phenotype. This has been linked to diets that are deficient in L-carnitine or taurine, or that are grain-free with a high legume or sweet potato content. Boxers are more at risk for L-carnitine deficiency, as are Cocker Spaniels. And of course, Cockers and Golden Retrievers with taurine deficiency should remain on our list, on our radar too. Chronic volume overload may cause the heart to appear dilated. Some breeds are predisposed to both hypothyroidism and dilated cardiomyopathy, like Dobermans. But if you have a patient diagnosed with a DCM phenotype in which this disorder is not considered familial, it really can be recommended to screen for hypothyroidism. Now, athletic breeds, they can have a remarkably globoid appearing heart. So Springer Spaniels and Sighthounds are notorious in this sense. That's where it can become a little bit more challenging with echo. So there's a lot to consider when it comes to this particular disorder. What are the hallmark features with echo? So it's predominantly a left-sided disease, although giant breeds more commonly have bilateral changes. You're going to have dilated, rounded chambers. Most importantly, poor contractility, decreased fractional shortening, decreased ejection fraction. And the fractional shortening can sometimes be below 10%. And very often, due to this dilation of the heart, you get this increased endpoint to septal separation and a central mitral regurgitant jet because the valves have been pulled apart. There's poor coaptation. Thrombus formation, it's rare, but it can happen, particularly with the tachyarrhythmias. So the European Society of Veterinary Cardiology developed a scoring system consisting of major and minor criteria. The major criteria are denoted 3 points each, and the minor criteria are worth 1 point each. A cardiac assessment should reach at least 6 points to make a diagnosis of DCM. The major criteria are left ventricular systolic or diastolic dilation, increased left ventricular sphericity, decreased systolic function, so decreased fractional shortening and decreased ejection fraction. Worth 1 point is a ventricular arrhythmia, atrial fibrillation, increased endpoint to septal separation, and left atrial or biatrial dilation. You can see here a DCM phenotype. In our right parasternal four-chamber view, we have a markedly dilated heart. The left ventricle is bulging, the left atrium is bulging. In fact, at the very top part of the left atrium there, this is going to be one of the pulmonary veins that's also bulging. In the short axis view, we can see a dilated left atrium. This M-mode trace through the mushroom view demonstrates almost no excursion of the interventricular septum and left ventricular posterior wall throughout the cardiac cycle. This can be appreciated subjectively, of course, but the numbers show the degree of systolic dysfunction. Remember, the fractional shortening should be between 28 and 45%, measuring just shy of 14% in this patient. And the ejection fraction, so the EF, should be above 50%, measuring 29% in this patient. This patient has very, very poor systolic function. The endpoint to septal separation, or EPSS measurement, is typically increased in patients with a DCM phenotype. A normal EPSS is measuring typically less than 7 millimeters. This patient with DCM has an EPSS measuring 1.23 centimeters. So this heart is big. This heart is big and round. As you can see, the staging of DCM is slightly different to mitral valve disease, as there is no subdivision of B1 and B2. Stages A and B are the preclinical stages, and stages C and D are the clinical stages, where the patient is presenting with signs attributable to the disorder, where the disorder is evident either in echocardiographic imaging or on a Holter study. So what does this mean for the treatment regimes for these patients? So there was the PROTECT study, like the EPIC study for mitral valve disease. The PROTECT study was a DCM study, and it recommends starting pimabendin plus or minus an ACE inhibitor in cases that are stage B, so when cardiac remodeling is present but clinical signs have not commenced. Moving on to the final topic of the lecture, again briefly, this is hypertrophic cardiomyopathy, a HCM phenotype in cats. So approximately 70% of cats with hypertrophic cardiomyopathy are male, and it's characterised by mild to severe concentric hypertrophy, so thickening primarily of the left ventricular posterior wall and the interventricular septum. There's of course breed predisposition, but very often we just see it in domestic short-haired cats. Approximately 50% of cats with HCM do not have a heart murmur, And approximately 50% of cats that have heart disease that go into congestive heart failure will have a triggering event. And this triggering event could be general anaesthesia, IV fluid therapy, or even a marked stressor. Hallmark features with echo. The typical features, you're going to have concentric hypertrophy, as I've mentioned, of the left ventricular posterior wall and the interventricular septum, both in diastole. And this can be measured. So if these parts measure more than 6 millimeters in any region of the left ventricular posterior wall or interventricular septum at the end of diastole, we have to start thinking about concentric hypertrophy. Very often there's papillary muscle hypertrophy. And there's end systolic cavity obliteration of the left ventricular lumen. So when the heart contracts, when you're looking at the short axis views, you don't see any lumen in the left ventricle. And sometimes you can have systolic anterior motion of the mitral valve. This is what a phenotypic appearance of HCM looks like. And you can appreciate here the image on the left. You've got your interventricular septum and the left ventricular posterior wall. They're measuring thick. Now, there's some debate about whether it should be over 6 millimeters. Some people say 5.5 millimeters should be the cutoff. But we say between 5 and 6 is kind of more of the grayer zone. And we're approaching the 6 millimeters, but we're definitely looking at thickness. And in the M-mode trace here, I think the thickness of the interventricular septum and left ventricular posterior wall can really be appreciated. It's very important to note that a HCM phenotype, that's to say a heart that appears hypertrophic, can be caused by several underlying pathologies. Idiopathic HCM is the most common form, but it's always recommended to rule out systemic arterial hypertension. So check that blood pressure, check the biochemistry for renal values in cats. Hypothyroidism, check the T4. With echo, you're going to be able to rule in or rule out with a more comprehensive study, aortic stenosis. Of course, you've got other causes of HCM phenotype include acromegaly, and in young patients, transient myocardial thickening. So that concludes this lecture. If you have any questions, please do not hesitate to reach out. It is now time to practice. So please try to practice the standard right-sided views. Look at those mitral valves, take measurements in M mode, and look at the systolic function. So thank you so much for your attention. I hope you enjoyed this lecture, and I look forward to talking to you soon. Bye.